Hey guys, am I audible visible? If so, let me know. Hello guys. Can you see me? Can you hear me? Can you hear me? Okay. I hope I'm audible and visible. So welcome back everyone. Hello Miduna. Hi. Good evening Archit. Hello Sonal. How are you? Hope you're doing good. Right. Great. Amazing. So let's start and revise pathology starting from chapter 1 and I'll be here till your entire completion of systemic pathology, right? Yes, Sonal. So what we'll be doing is I'll give you topics. I want you to use this post-prandial session whenever we generally tend to sleep to be a little bit more productive. We'll do 3 days a week class for pathology. I want you to read for half an hour to 45 minutes. Whatever notes you follow, please go ahead. Hello, Kalra. And just come here for revision of MCQs. That's all. So a tiny topic of let's say 3-4 pages every day, and then we'll revise that so that till your FMG exam or your INACT exam or your NEET PG, all of them kind of fall in the same age timeline, right? Like May, June, July. We'll try to revise everything starting from general pathology, hematology, and systemic pathology. And if you are done, we'll go the second round of revision as well, right? Hello, I'm good. How are you, Sarji? So Indian in China, how are you? I hope you're doing good. Right. So with that note, I'm going to definitely I'll do it. I'll do it entire thing like I said, Sonal. First revision we'll complete chapter wise little bit breakdown of topics. Then we'll go maybe chapter wise, and that last we'll go T&D of general path one, MAT one, and systemic path one. Fine. Okay. But I want you guys to be interactive. I want you guys to comment on the answer because you just now read whatever we are going to discuss, and let's revise. Please don't come to the class without reading because this is going to be a second round of revision in addition to whatever you have read already, right? Comment on the answer. Primarily PYQs, that's a target, and something in and around that. What do you guys think is the answer? I want everyone here online to comment on the answer. Which of the following is an electron microscopic change of an irreversible cell injury? Archit has gone with B, Chandu has gone with B, others? Hello, Vansh, hope you're doing good. B, great. Okay, so the question is asking on irreversible cell injury. Generally, when you read electron microscopy, we must have read mostly regard with the reversible cell injury, right? Disruption of ribosomes is a reversible cell injury finding. Swelling of endoplasmic reticulum is also a reversible cell injury finding. Cell swelling obviously is a reversible cell injury finding, right? Actually, if the question had only amorphous deposit, that also is a reversible cell injury finding. The thing is here, when you have a large amorphous deposit, it is more in favor of irreversible injury, right? Just since we are in the topic, I'm going to ask you a question which is related to that. I want you guys to comment. There are two findings in electron microscopy which are more in favor of irreversible. What were they? The two findings which can be seen in both reversible as well as irreversible. What are they? Apart from the disruption, swelling of endoplasmic reticulum cell, everything else, two findings common for both reversible and irreversible cell injury. One is obviously your perfect channel, one is myelin figure, and other one is your amorphous deposit, right? So these are the classical findings in electron microscopy in a cell injury, which can be seen in reversible. Disruption of ribosomes, small amorphous densities. Please look at this, small. If it's small, it's reversible cell injury. Reversible, reversible, reversible. And there are two findings, both myelin figure and amorphous density of mitochondria are seen both reversible and irreversible. So how do you differentiate this? If it's a large amorphous density, obviously I'm going to go for irreversible, and more quantity of myelin figures, I'm going to go for irreversible cell injury, right? So the distinction is just based on the quantity, but both are common findings for both reversible and irreversible cell injury, right? Clear? Let's go to the next MCQ. Last time I got only 10 responses. This time I want more responses. Who is online? I want you guys to tell the right answer, right? Simple, easy things. First chapter is generally easy, right? Only when it goes to hemat and systemic path becomes a bit difficult. Read the question. Don't jump into the answer by looking at the image. Read the question, then let's go to the image. Okay, Chandu has gone with A. Anyone else? Sonal has gone with A as well. Like I said, I want everyone to listen, read, and comment. It's fine if you're wrong. Here, our goal is to make mistakes. Fine, great, amazing, everyone, right? Let's read through the question. A 38-year-old person experienced with severe abdomen pain, okay? On the past day, she is hypotensive and now she is in shock. Lab study shows an elevated serum lipase. Now tell me, right? Not at all. Now tell me, when you have a patient with an elevated serum lipase, what's a clinical diagnosis? I'm not even going to the rest of the question, right? So when you have a clinical scenario, it's like seeing a patient. Please imagine you see a patient with history. You definitely will come to a presumptive diagnosis. Then you investigate. Then you make sure the diagnosis is correct, right? Elevated serum lipase, elevated serum amylase. You have only one diagnosis. What is that? Can you guys tell that? It's pancreatitis, right? So obviously, it's a pancreatitis. The first thing which will come to my mind from the representative gross specimen, which is actually that of a mesentery set, is a gross specimen, right? Perfect. Right? It's an acute condition, most likely pancreatitis, because very severe abdomen pain for 1 day, right? So this is an omental lesion, and what are these? The classical image from Robbins, these are nothing but omental calcification. So calcification, the omentum can happen due to pancreatitis because the enzymes go outside and destroy the omental wall, right? So the answer is absolutely right. It's an acute pancreatitis. Right, saponification seen on the ground. Archit is bang on its answer. I'm just going to extrapolate this to one more important question in surgery. It's a 38-year-old woman having acute pancreatitis. Let's assume, right, on good note, let's assume that woman is not drinking. What's the second common etiology for pancreatitis? Apart from alcohol. Apart from alcohol, I would want you to think of this when you think of pancreatitis. What do you think is the cause? Perfect, Nandita, right? Gallstones. Please don't always be little bit of a presumptive notion. Every pancreatitis is due to alcohol. Actually, gallstone-induced pancreatitis becoming a little bit more common than alcohol, right? Because of the binge drinking of alcohol is kind of reducing over the period of years, right? Gallstones and alcohol are the two major cause of pancreatitis. Perfect, amazing, right? Let's go to the next question. I'm sure you guys will answer this. PYQ, similar ones, but do comment. It's okay if you make mistakes. Okay, Sonal has gone with B. Abrar has gone with D. Gagan has gone with C. Others? Archit has gone with C. C. Good. Okay. So how many of you in this question did read this? You saw fibrinoid necrosis and then jumped to the answer. You might have, some of you might have. If you've done that, please make sure don't do this in the real exam. Because these are silly mistakes you can avoid. Please don't be in a hurry. You have easily 45 seconds to a minute for every question. Please don't be in a hurry, right? So fibrinoid necrosis is seen in all of the following except, yes, obviously I'll see in malignant hypertension. Yes, I will see in polyarteritis nodosa because like Chandu said, it's a vasculitis, right? It's a vasculitis. Any vasculitis for that matter, you will see fibrinoid necrosis. Ashoff nodule, heart is considered like a bigger vessel, so heart damage, again I'll have fibrinoid necrosis. You will see fibrinoid necrosis here also. Diabetic glomulosclerosis, it's actually not a vasculitis, it's a vasculopathy. We don't cause diabetes as vasculitis, we call them a vasculopathy, right? Here, there'll be a deposition of the age products. That's what is causing the problem. It's not vasculitis. So obviously in diabetic glomerulonephritis, you will not see fibrinoid necrosis. That's the right answer. A easier way to remember, oid means like. Fibrin is fibrin, which is seen in vessel wall injury. Fibrinoid necrosis is equivalent to vessel wall necrosis. Just remember this. Never forget this. If you have a notes, if you have a table, just write down on it. Yeah. Yes, Chandu, KW lesion is a deposition of the age product. That's why you have this. That's not a necrosis. That's not a vasculitis. Whenever you have a vessel damage, it's going to result in fibrinoid necrosis, malignant hypertension, like you said, SLE, any vasculitis, Ashoff nodule can have fibrinoid necrosis, right? Perfect. Again, there's an image from Robbins. This might come in an exam. This is what your blood is. You can see the center, and this entire pink lining here is your fibrinoid necrosis, right? You can classically see a fibrinoid necrosis lining the entire blood vessel wall, fine. An extra additional point, especially if you're aiming for an INICT like exam, PAS pass is positive in case of fibrinoid necrosis. Just remember them. If they want to ask a little bit of a higher question, they might ask you one marker which will be positive for fibrinoid necrosis, PAS, right? Yes, everything will lead to any type 3 hypersensitivity response will definitely have your vasculitis. So obviously it will lead to fibrinoid necrosis, right? Amazing. Read carefully. You need not be first in the comment box. Just be right in the comment box. That's more than enough, right? I'll give you enough time for you to read. Okay. Read the entire question carefully and tell the answer. Please don't jump to the answer. What do you think is the right answer? I'll keep quiet. I want you guys to comment. It's not a PYQ, but it's definitely a simple one. Answers? Our clock is ticking, right? 45, 30, 35, 20. Comment on something. You need not be right. Just comment on it. We'll go through it for sure. Okay, Aju started. It's starting with B. Others. It's A, B, C, or D. That's all. B, B, D, B, B. Amazing. Fine. Got it. You got a decent response. Now let's go to the question. A 59-year-old female who's an alcoholic brought to the emergency room with fever, foul-smelling breath. Subsequently, the patient has an acute bronchopneumonia, right? And it's classically given the patient has pulmonary abscess, which is identified at autopsy, right? So this finding here, you can see this finding here is an abscess cavity, right? So the question is very simple. If I do a histology of this abscess, what do I see? Okay. So now, what is the finding seen in abscess? What type of necrosis? Now we have divided the question a little bit. The question is simple. What is the type of necrosis seen in abscess? Coagulative, liquefactive, caseous, or fibrinoid? Abscess will always have only one type of necrosis, which is liquefactive necrosis. Please do remember, liquefactive necrosis can be seen obviously in your brain infarct, right? So you cannot forget that. That's where you see it. Okay. You will see them in abscess cavity. You will see them in any suppurative lesion. Any suppurative inflammation, you will see liquefactive necrosis. Do remember, don't forget it. And what type of gangrene? I'll come to that too. What type of gangrene you'll have liquefactive necrosis? Dry gangrene or wet gangrene? Obviously right, right? In case of an wet gangrene. The reason why in wet gangrene I have liquefaction is the amount of inflammation is very, very, very high. Whenever there's high amount of inflammation, like suppurative inflammation, like an abscess formation, like a wet gangrene, you will see liquefaction, you won't see other things, right? Do remember, there's an extrapolation of that, right? Yes, perfect. So the only reason quite a few of you might have made a mistake is if you looked at the lung alone, by default, lung means caseous, right? That's a preset notion. You might miss it. So that's why it's not just the gross. Also, I have a question which is written pulmonary abscess is the diagnosis. I can change this question giving a radiological image of an X-ray finding with your classical the appearance of the air and the solid areas, right? You have a classical appearance for pulmonary abscess that can also be given. So it's easy for you to miss it. So please be careful. Anything suppurative, any inflammation, think of a liquefactive necrosis, right? Great. Okay, let's go to the next one. A simple one and a clinical scenario. Let's have a mix and match. What do you guys think is the answer? This doesn't require 35-40 seconds, right? In apoptosis, PAF is activated by release of which of the following substances from mitochondria? D, Gagan, Kalra, others, D. Okay, great. So the question is simple. Maybe here there's a little bit of wordplay that might have taken you a little bit of a longer time, but it's fine. You took your time, but you wrote the right answer. That's what is more important than the time here, right? Perfect. APAF, the question is not which is caused because of activation of APAF. The question is cytochrome C, right? So from mitochondria, the cytochrome C comes to the cytoplasm. Like you guys know, it will bind with APAF 1, which forms, like some of you say, apoptosome. Okay, so apoptosome formation will activate which caspase? Can you guys name that caspase here? What caspase will be activated here? Which caspase will be activated here? Caspase, it's intrinsic pathway. Caspase number 9, right? You'll get an caspase 9 activation here. Fine. This mitochondria plus cytochrome, APAF is causing caspase 9 activation. Amazing. Fine. Just to recap your steps of apoptosis, because you know that apoptosis is one of the important thing and something which you learn for a long duration, right? We have to relive Robbins. We have to get out of these notes things and we have to go back to Robbins. If you have an irradiation, that's mutation or lack of survival sickness or a DNA damage, will activate your senses of cell stress. If you remember, these are your BIM, BID, and BAD, right? So the sensor of cell stress will be activated. That sensor will have two mechanisms. One, they will antagonize or destroy BCL2. What is BCL2? Pro or anti-apoptotic? Can you guys answer? BCL2 is perfect. BCL2 is an anti-apoptotic gene and will activate this guy. This guy is backs and back. Backs and back are your pro-apoptotic channels. If you see here, it will be activated. That will release the cytochrome C outside the mitochondria. This cytochrome C binds with APAF, which forms your apoptosome. Apoptosome is a combination of proteins which activates your caspase, right? So this is the simplest way of explanation of your intrinsic pathway of activation, right? These are very simple things. Robbins have amazing flow charts. Read them, revise them. That's going to help you in a longer term than anything, right? Great. Next question. Let's try kind of a tiny clinical scenario. Let's see if you won't make a mistake. I hope you won't make a mistake. What's the right answer? Answer. I'll read the question. A pathologist is examining a biopsy of an individual's left ventricular myocardium and notices cardiac myocytes are being enlarged. In other words, it's going to translate to I'm having a left ventricular hyperplasia or hypertrophy. What do you think will happen here? Hyper? You're going to fill it. It'll cause hypertrophy, right? Perfect. So hypertrophy of the left ventricle is there, and obviously one of the commonest answers is systemic hypertension. Let's say the answer is pulmonary hypertension. Okay, let's assume the answer is pulmonary hypertension. What should change on the top? Hello, Tata. Good evening. Good afternoon. What should change on the top? Let's assume the answer is pulmonary hypertension. What should change? Should anything change or same history? It should change. Perfect. It will become right ventricle. So the concept remains the same. So please read through the question carefully. You might have a subtle change and the answer might change, right? I can have an regurgitation, different ventricle, aortic, different ventricle tricuspid, right? Perfect. Okay. Lambert's excrescences are just a normal, like an age-related finding seen in aortic valve, will not cause a problem, and patent fossa valve is not going to cause a left ventricular hypertrophy, right? And this classical left ventricular hypertrophy seen in systemic hypertension. Okay. Again, a one-liner, one new, one old question. It's a simple question. Everyone will answer this, right? This long time for this is not good. Stepladder pattern of DNA electrophoresis in apoptosis caused by which of the following? This part you know, guys know, right? Stepladder pattern is seen in apoptosis. That I'm sure everyone is aware of. Okay, what is the pattern seen in necrosis? What is the pattern seen in necrosis? In necrosis, you have perfect. You have a smearing pattern, right? Great. So stepladder pattern is seen in apoptosis. The reason for the stepladder pattern is endonuclease, because endonuclease cuts at your palindromic sites. So I have a DNA like this. The endonuclease cuts only at the palindromic sites, right? That's like a restriction endonuclease, right? They cut at palindromes. So when I cut at palindromes, obviously I will not be able to destroy it completely. The only thing I'll do is I can fragment. I can fragment. I can fragment. When I run an electrophores of these tiny fragments, I'll see stepladder, right? I will see these. This is my fragment. This is a 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 fragment. The reason for stepladder pattern of electrophore is your endonuclease activation. Please go with the concepts. Don't go with facts. You might miss it. Since it's endonuclease, it's being cutting into fragments, and I have stepladder pattern. In case of a necrosis, what I have is a nuclease. It's not an endonuclease. It's a nuclease. Nuclease means it will destroy till I have DNA RNA. Till I have nucleic acid. That's why necrosis results in a smearing pattern. It'll destroy everything, it'll smudge out everything, so it looks like a smear and not like a stepladder, right? That's a difference between your stepladder and your smearing pattern. If this came once in an AIMS exam, if it repeats, I'm 100% sure you will answer, right? Now, just to complete for namesake, what's happening here? What is this? I'm sure you'll answer. What is this? That's your perfect. That's your normal protein, right? That's a completely normal one. That's a normal cell where I have a single molecular weight DNA. Okay? There's a single molecular weight DNA, which is a completely normal cell, which is not destroyed at all. Amazing. Great. Fine. Perfect. Please do remember, not just the pattern is required. They might ask you as an extrapolation, what is the reason for the pattern? Endonuclease for stepladder and nuclease or a DNA is for your necrosis. Fine, perfect. Next question. Maybe kind of looks bigger, but simple. Read through the question, understand what they are asking, and then go to the answer. Read the question, let's see what's the problem. The formation of fingers and toes in a developing fetus requires the removal of tissue between them, right? Which of the following, which occurs to an organized process? Which of the following is widely known to block this process, right? We'll step by step break this question. If it looks difficult, let's step by step break the question. The question says that when we were in the embryo, these fingers were united, and someone is breaking this unity and making them fingers, right? What is the process? What causes cell death? It's by apoptosis, right? So this embryological process of cell death is due to apoptosis. The question is now very simple. Which of the following genes is known to block apoptosis? Or perfect, like you guys answer, which of the following is an anti-apoptotic factor, right? It's a classical physiological apoptosis, and obviously an anti-apoptotic factor, like you guys said, is your BCL2, right? Remember, anything with L, a gene with L, that's kind of a clue here, has a longer life, which is anti-apoptotic. BCL2 is anti-apoptotic, MCL1 is anti-apoptotic, BCLXL is anti-apoptotic. Always when you use shortcuts, there will be a problem. There's one more gene with L, but also S. BCLXS is pro-apoptotic. Just remember, you might miss this. It's a very easier clue to remember, which is anti-apoptotic and which is pro-apoptotic. BCL2, MCL1, your BCLXL is anti, and S for shorter life. Remember like that, it's pro-apoptotic, right? Perfect. Next question. Again, might look bigger, but not difficult. Very simple. Read it carefully and tell the answer. I'll keep quiet for some time, then I'll try to explain it. That's also a good thing. L for lowering apoptosis. Okay, let's read the question. A 90-year-old male with dementia has been bedridden for 5 years. The patient's upper limb and lower limb were examined, and there was a reduction in the circumference of the upper and lower limb. Which of the combination of the molecular mediators is responsible for this? Now let's see what is the process happening here. So I'll rephrase this question. I want you guys to answer. Which of the following things is happening in this person's lower limb and upper limb? Hyperplasia, hypertrophy, metaplasia, atrophy. What's happening to this 90-year-old person ideally? Post dementia, bedridden for 5 years, not at all using the limbs, bedridden completely. So obviously it's an senile atrophy. Okay, it's an atrophy, right? The person is not using, it's a disuse atrophy, that's all. Person's atrophy, the limbs have been atrophied. Amazing. So if you have an atrophy, cyclooxygenase thromboxane A2 is involved in your inflammation. It's not going to be for atrophy. Lipoxin and your lipoxygenase, again inflammation, not an atrophy. P53 backs, which pathway do you think this will involve? Can you guys answer? Which pathway will P53 and backs trigger? Or which pathway it's involved? Hyperplasia, atrophy, metaplasia, or apoptosis? It will cause apoptosis, right? Just now we saw, right? Apoptotic gene, pro-apoptotic gene, your backs is a pro-apoptotic gene, right? So atrophy is due to ubiquitin proteasome pathway. Because in ubiquitin proteasome pathway, all the proteins are being tagged and they are being destroyed, right? Atrophy, ubiquitin proteasome pathway could be answer. Also your autophagy. If this is not there, look for autophagy. That could also be the mechanism of atrophy. One more question. We'll try to extrapolate from this. Because of this ubiquitin proteasome pathway or autophagy in atrophy, in microscopy, I will see a pigment. Can anyone name the pigment? I'll see a pigment in atrophy because of this ubiquitin proteasome pathway or your autophagy. What is the pigment? Brown color pigment, like a wear and tear pigment. That's your classical. Great. Lipofusion. That's why we call atrophy always a brown atrophy, right? So we use the term brown atrophy because of the lipofusion granules, right? Amazing. That's an amazing answer, right? Super. Right? Let's go with one more question. Again, might look bigger, not big. I'm 100% sure you'll answer. This is the last question for the day, and I'll go with few classical one-liners after this. Tigroid hard or liposuction, right? What do you think is the right answer? Yes, Chandu, perinuclear in location. Simple one. Let's see. There's a trap here. Let's see how many of you are falling for the trap. Okay, I'll tell you the trap now. 35-year-old obese woman experiencing heartburn, gastric reflux, 5 year because of eating large meals, right? So tell me, what is the problem happening here? What is the diagnosis? Can I say the patient is having kind of a Barrett's esophagus and GERD, right? So the question, the primary thing here is GERD induced Barrett's esophagus. Okay, is GERD induced Barrett's. So if it is GERD induced Barrett's esophagus, you know for a fact it's a metaplasia. Some of you wrote goblet cell hyperplasia as the answer. This is wrong. Goblet cell is right, but here it's not hyperplastic. Right? It's not hyperplastic here. I didn't put the image because this doesn't require an image, right? That's why Nandita. This by I wanted to make sure that you can solve a question without an image. It's a GRD, long-term endoscopy biopsy taken. Obviously, you'll think of an Barrett's esophagus, right? So microscopy had the same thing. I don't want it to be present because you might end up in writing this is the wrong answer, right? B is wrong here because goblet cell metaplasia is an absolutely right answer, but it's not goblet cell hyperplasia. That's why it's wrong. Columnar metaplasia is a better suited answer here, right? So for everyone who answered B, you got carried away by the first half, goblet cell. Please read the entire option. That's a trap here. It's in columnar metaplasia, or I can use the term glandular metaplasia, or I can use the term goblet cell metaplasia. But it should be metaplasia, not hyperplasia, right? All these are one and the same. So obviously the right answer here is in columnar metaplasia. You can solve an image-based question without an image. The answer is this. Quite a few of you answered it, right? But next time, please be careful about the entire option, right? Let's go to a few one-liners. Fastest finger first. What is the most common cause of cell injury? Comment. Most common cause of cell injury? Perfect. Hypoxia or ischemia. Whatever is there in the option, go with that, right? Whatever may be their answer, fine. What's the most common type of necrosis? Again, fastest finger first. Most common type of necrosis? Perfect. It's your coagulative necrosis, right? Are all the cellular adaptations reversible? Yes or no? Third is just a yes or no question. Are all of them reversible? No. Not all of the cell adaptations reversible, right? I do have an exception. Exceptions are always there. The exception is the next question. Give an example of a cell adaptation which is irreversible. Superficially, yes, but if I'm going for an MCQ, I would say definitely not all are reversible because I do have an irreversible cell adaptation, and that is atrophy. Perfect, right? Some, not all case of atrophy, some cases of atrophy will be irreversible. I'll give an example. You guys are adults, you don't have a thymus. Do you think thymus will come back? Thymus will never come back, right? That's an irreversible atrophy. After menopause, do you think menstrual cycle will come back again? It won't come back, right? Nandita, metaplasia is also reversible if the stimulus is removed. For example, Barrett's esophagus can come back to normal if GRD is corrected, right? But atrophy is the only thing which can be irreversible. So that's an example here, right? What's the most common ion seen in reversible cell injury? Fastest finger first. Just two options, sodium or calcium. Na or Ca? Perfect. The reversible cell injury answer is sodium. What's the most common ion in cell death? In reversible cell injury, it is sodium, and in cell death, it is calcium, right? So please do remember, in reversible cell injury, what happens is your sodium potassium ATPase does not work. So lots and lots of sodium accumulates, which assumes or pulls the water, which results in cell swelling, right? So for reversible, it is sodium. Irreversible or cell death, obviously it is calcium, right? These are few one-liners which is there in the first topic, right? Okay, that's all for today's class. We'll do this every day on the post-prandial session, 3 days a week, not every day, 3 days a week. Tomorrow I'll put the schedule in the WhatsApp and the Telegram. I'll prefer WhatsApp because Telegram is more of bots and scams these days, right? So I'll put in the channel or the WhatsApp the PDF of this as well as what you have to read tomorrow, right? So if you have any doubt, you can ping me on the WhatsApp. I'll try to definitely reply, or on Insta. Fine. See you soon. Thank you, guys. Hope today's sleep was taken care of, right? This like this, I'll take care of 3 days a week sleeps, and definitely you won't sleep in the post-prandial session. Bye bye. Thank you.